So today we are going to discuss the basics of intubation in ICU. Okay, intubation basically, if we see, it's an elective procedure in operation theatres. But if we come to emergency or ICU setting, it is an very emergency procedure. Just like God gives us life, we have to save the lives. So for saving the lives of patients, we need to intubate. And we need to intubate, we have to be on the target, else the patient dies in front of you. So you can't expect or you can't manage to have a second go or third go if you are not able to intubate a patient. If you cannot intubate, the patient dies then and there. Okay. So everybody has got, what I could feel that everybody has got different techniques of intubation. Somebody will give a paralyzing agent first, somebody will give an induction agent first, somebody will give a sedating agent first. It's different for everybody, right? Now the motto of this class is to standardize the basics. What is a standard? I am not talking, I'll not include a word or based on my experience, but whatever I would be quoting, it will be based on the standard guidelines based on all the difficult airway society which has been formed across the globe. So as per the society guidelines, it says that whenever you intubate a patient, you have to classify couple of things. First, the patient should not have a dreadful experience, okay? Because when you are intubating a patient, it's not like patient is dead, patient is alive, patient is aware. Many a times we go for awake fiber optic intubation, okay? We'll be discussing here. So the patient is awake and you can't just treat him like a cattle, okay? Hospital industry is just like a hospitality industry, okay? We need to take care of that. So we need to take care of analgesia, which is like patient should not have any pain. We need to have proper amnesia. Amnesia is like for making the patient forget everything, whatever is happening to him inside the hospital, ICU campus or inside the emergency room. Analgesia, amnesia, and then complete obtundation of all the reflexes. What reflexes? The corneal reflex, the cuff reflex and the gag reflex. The patient should not have all these reflexes when you are intubating a patient, because if you intubate and the patient tears falls down, that means it's not a successful intubation, okay? So for analgesia, the best thing that is available in any ICU setting is fentanyl, okay? You can use other analgesic, but an opioid is always preferable when you are intubating a patient. So if the supply of fentanyl is not there, you can always use something like midazolam or something like ketamine, okay? So analgesia is very important, and mind you, propofol does not give any amount of analgesia. If you are thinking that propofol is going to give analgesia to the patient, you are wrong. Ketamine gives a good amount of analgesia. Midazolam is also just, it potentiates the GABA. It has very less to nil analgesic action. It has predominantly sedative action and amnesic action. That is, it makes the patient do not remember what is happening to the patient. So first you need to take care of the sedation part, then analgesia part, then amnesia part. After taking all this, and fentanyl actually takes care of all the three components. It causes good amount of analgesia, it causes good amount of amnesia, and it is a good induction agent, okay? Apart of that, there are specific induction agents that are available in ICU. You can use either thiopentone, propofol or etomidate. These are the three induction agents that you will get everywhere in the ICU. And there will be places where you will not get etomidate, because etomidate is relatively costly. But that doesn't mean that you will use anything, okay? So these are three induction agents. So after giving fentanyl, you have to give some induction agent so as to intubate the patient, either one of the three, okay? So if you have ketamine is okay, propofol, thiopentone. So the main problems for using any of this, suppose let's start with propofol. What is the main problem with giving propofol? In ICU or in emergency setting, you will see most of the patients having hypotension, right? Patient's BP will be less, patient will be on NORAD. The moment you shoot on propofol, the patient's systemic vascular resistance decreases, the patient will go into gross hypotension, okay? So you have to take care of that. That we always be aware that when you are using propofol, it has to be associated with a decent blood pressure. If the patient blood pressure is already low and you are pushing in propofol, the patient is bound to go into shock, okay? So the better part is using etomidate. Etomidate does not decrease the blood pressure, etomidate does not decreases the heart rate, etomidate does not cause any amount of increase in ICP or anything, okay? only one side effect that the intermediate has is adrenal suppression. Okay, so but that is a rarity. It's not very common that okay to the extent of 30%. It is like somewhere around 10, less than 10%. So intermediate is one of the most cardio-stable induction agent that you can find in any ICU. Dose is like 0.1 to 0.2 mg per kg body weight. You can go till 0.3 mg per kg body weight. Okay, so remember intermediate is always better. So you can use fentanyl, you can use intermediate. It's not like you will not use propofol or thiopentone. In most of the neurological cases where you want the ICP not to increase at the time of intubation, you can use thiopentone to the dose of 3 to 5 mg per kg body weight. So these are your induction agent. Apart of fentanyl, you can use propofol. Propofol at what dose? Almost 1 to 2 mg per kg body weight. Intermediate at what dose? 0.1 to 0.2 mg per kg body weight. And the third is ketamine. Ketamine you can go till 2 to 3 mg per kg body weight. Okay, you can go till 5, but then 2 to 3 is the preferable dose. So after this, the question comes is whether you should give paralysis or not. By paralysis, I mean to say whether you are going to give succinylcholine, rocuronium, vacuronium, atracurium, cisatracurium, whatever you want to give. Okay. Succinylcholine is like one of the most commonly used drug, but then it has got a lot of issues. Okay. Succinylcholine is one drug which is going to be increasing all the pressures in the body from head to toe. It increases the intracranial pressure. So any neurological patient who has got a IC bleed or a stroke in whom you are suspecting a raised ICP, you should not use choline. Fine. Any patient who is hyperkalemic, it will cause more hyperkalemia. You should not use succinylcholine. Any patient who is having pneumothorax, it will increase the intrathoracic pressure. Any patient who is you are suspecting a gastric reflux, it increases the intragastric pressures. So you should avoid succinylcholine. That is why succinylcholine is not very famous in ICU. In ICU setting, you use something like maybe rocuronium, which is again a shorter acting paralyzing agent. Atracurium you can use, which is like relatively short acting, not exactly short acting. Short actings are very less, so it is relatively short acting, in which the duration would be like the duration of succinylcholine is around 8 minutes. The duration of atracurium is around 20 to 25 minutes. So if you are confident that you will be able to ventilate the patient after giving the paralysis, then only you should be pushing in the paralyzing agent. Else, with use of high dose of fentanyl and with use of decent dose of intermediate, you will be able to get a check laryngoscopy done. Okay. The moment you do the check laryngoscopy, this is the laryngoscope, as I tell you, always check the light and the blade first, and then just do a check laryngoscopy. Okay. If you can see visualize the vocal cords, fair and well. If you cannot visualize the vocal cords, don't give the paralyzing agent ever. Okay. Because if you have a helping hand, fair and well. If you don't have a helping hand, the patient can go into respiratory arrest and could not be revived. Okay. So always think twice that okay, if you are able to intubate the patient, it's good. If you are not able to intubate, whether any helping hand is nearby or not, whether you have got a backup or not, never ever hesitate in calling for help while intubating a patient. Okay. You should be the first person always to call for help. Whenever you are intubating a patient, a helping hand is always more than acceptable. Fine. So these are the basic requirements about drugs. Now coming to patient. While intubating, what are the things that you should look at? Okay. The first thing and the most important thing that I would like to tell you is this part. If any patient who is getting intubated and if the monitor is not there, I don't think the patient is fit for intubating. Okay. You should have the proper ECG, you should have the proper saturation, you should have the proper blood pressures. After that only you go for intubation, otherwise no. Okay. Then you need to check whether any IV access is there or not. Okay. So first the monitors, then the IV access. Thirdly, your instruments. What is there in your instrument profile? Okay. By instrument profile, what I mean to say, this is only a laryngoscope. Okay. Many a times it will happen that the tube does not go with isolated laryngoscope. You need some other accessories to get in the tube. So what you have to check whether you have got any stillet or not. This is a stillet. You have to check whether there is a stillet or not, because no matter, I have done more than maybe 5,000 intubations, but even today I always check for backups. Just like your house needs a backup when the electricity goes off, the patient needs a backup when this instrument is not sufficient enough to intubate the patient. The first thing that you will need is the bougie. Okay. sorry, this is a stillet, and then this is the bougie, the longer one. Okay, so these two things are mandatory whenever you are intubating a patient. Again, now coming back to the patient, you have used the monitor, you have used the IV lines. Okay, there are few things that you need to look at the patient before intubating a patient. You are in ICU. I know ICU is a very hectic environment, or ER is a very hectic environment, but you have to have a quick look at the patient, whether your patient can be intubated easily or not. There is a mnemonical lemon. Like, first you have to look at the patient. Okay, look in the sense, many Sardarji can come who have a long beard. Nowadays it's in fashion also to keep people having long beards. People with long beards will have a difficult intubation, will have a difficult bag and mask ventilation. Okay, so you have to look at the patient. Then you have to look whether the patient is morbidly obese or not. A BMI of around 30, 35, you have to take care. Okay, this patient is going to be a difficult, you can call for help. Okay, so you have to look at the patient. The E part of the lemon is evaluate. What do you evaluate? If the patient is vocalizing, you have to see there is a formula for 3-3-2. Three fingers between your two incisors, like these are the two incisors. Three fingers are going on, that means you are safe. If less than 3 fingers are going on, you are in danger, as well as the patient is in danger. So this is a 3. The second 3 is from the mental protuberance to the hyoid bone. If you have a 3-finger distance between the mental protuberance and the hyoid bone, you are safe. If it is not, that means you are in danger, because lot of people will have short neck, then the 3-finger will not come. Then there is 2-finger, 3-3-2. 2 is between the hyoid cartilage and the thyroid cartilage. There should be at least 2 fingers distance. Okay, so these 3 things you need to evaluate. Then you have to see the Malampati grading, LEM. Okay, Malampati grading, it's a proper grading which you need to remember. There are 4 grades like pillars, uvula, soft palate and hard palate. If all 4 are visible, that means patient is good enough. If the pillars are not visible, uvula, soft palate and hard palate is visible, grade 2. If even the uvula is gone, only soft and hard palate is visible, grade 3. If only the hard palate is visible, then means grade 4. Okay, so you have to evaluate the Malampati of the patient, and then when you do a check laryngoscopy, Cormack-Lihani grade is there, which you will read subsequently. So you have looked at the patient, you have evaluated at the patient, then you have seen the Malampati, then you see any obstruction is there or not, or the obesity component is there or not. Or by obstruction, I mean to say the patient may have an oral tumor. You will not be able to intubate that patient. You have to take care of that. You have to call your ENT friend and then get the intubation done. Okay. So any obstruction, oral tumor, oral cavity. In this patient also we saw a lot of oral issues are there post-oral surgery. If any obstruction is there in the oral cavity, the patient won't be able to be intubated. Okay. So O. And last but not the least, N is for neck movement. The flexion and the extension movement is adequate or not. Okay. Now coming to the position. Ideally, if we see the position of intubation should be as high as possible. If we see the books, it should be at the level, the bed should be at the level of xiphoid process, Ear's xiphoid process. So even when the maximum height of this ICU bed, I could not achieve that height. So this should be your ideal height of the bed that you should intubate it, not like bending down and then working hard for that. The height should be maximum. There is a specific kind of pillow that is used for intubation, that is called the Popit's pillow. Okay, by Popit's pillow is like 5 centimeter height pillow, okay, which you put under the neck, under the head, basically under the occipital. There is specific position that you need to intubate, which is called the sniffing position. Okay, what is sniffing position? Sniffing position, when you position the patient, the position of the external auditory meatus and the level of the sternal notch should be in the same line. This should be at the same line. This is called the sniffing position. In the sniffing position, you need to intubate the patient. When you intubate, you have to take care that you have checked your scopes nicely, and then you go inside, and after visualizing the vocal cords from the right side of the scope, you will just push the endotracheal tube. Fine. We have covered the drugs, we have covered the instruments, whatever we have. Okay. Now supposedly, this class is specifically for ICU things. Supposedly, we have tried this and the patient could not be intubated. We have tried with the stillet. We have inserted this stillet in the endotracheal tube, and then we have tried to insert the endotracheal tube, but still the patient could not be intubated. Okay? We have lost one accessory. The second accessory that you have is the bougie. What you do is just push the laryngoscope, see what should be the position tip of the laryngoscope. when you go inside, you have to see it should be at, once you see the epiglottis, you should go and then it should be at the tip of the vallecula. Okay. So this should be the position of the tip of the laryngoscope. Now what you can do is, if just the anterior part of the vocal cords are visible and the posterior parts are not visible, you can use the bougie and then railroad the tube. Okay. Supposedly even that is a failure. What do? You have tried the bougie, you have tried the stillet, but both of them are failure. What you can do is, you can use the McCoy laryngoscope. This is the McCoy laryngoscope. It will increase the visibility by almost 1 grade. Okay. You go inside there like a normal laryngoscope and then just push the trigger. This is the trigger. If you push the trigger, it will increase your visibility. So you can try again using the bougie or the stillet by using this McCoy laryngoscope. Okay. Even this is a failure. 5 attempts, all failure. By the time you have to call someone for help, okay, if someone is coming well and good, then this can be a life savior. This is called the laryngeal mask airway. Okay, you are not able to intubate the patient. Use this laryngeal mask airway. How do you use? You just hold it like a pen. You hold up a pen. Your index finger should be here and then the thumb should be at this position. Just show it nicely. This should be the position. Okay. This should be the position you should hold a laryngeal mask airway. Open the mouth, just glide it in. This should be anteriorly. Okay. Just push and jelly, hold it and just push it in and then just inflate it. It should be inserted in a semi-inflatable position and then once it goes inside, you should inflate it. Okay. There are various kinds of LMS which we can't discuss in this small class. Fine. Okay. Supposedly you have tried this. Again you failed. Is there any other option that you can save the patient? Yes, we do have. We can use this. In most of the ICUs nowadays, this is available. This is called the ambuscope. If you have a backup for fiber optic laryngoscope, fair and well. If you don't have the backup, you can use the ambuscope. It's as good as a fiber optic laryngoscope. You just need to railroad this endotracheal tube on it, go through the oral cavity, you will see the vocal cords. Just show here. This is what it will be visible here. So once you go here, see the visibility is good. Someday we will have a live session on fiber optic laryngoscope on a patient, but then as of today I can just show you till this much, that you should go in through the oral cavity, push it anteriorly and then go. You will see the vocal cords. Once the vocal cords are visible, go inside, trace till the carina and then railroad the endotracheal tube. Okay. This is the most definitive way that you can secure an airway. Even if this can fail, there will be times when even this can fail. So what are the other options that you can have? Apart of this, you can go for cricothyroidotomy. Okay, or last option is tracheostomy. So this is all about airway, intubation that you need to know, and you need to follow the basic protocols, what drugs you need to use. Okay, fentanyl. Okay, if fentanyl is not available, there will be many centers where you will be working and fentanyl is also not available. It's an opioid, it's a banned drug. You can use midazolam. Okay, etomidate, costly drug, available only at selected centers. You can use propofol. You can find thiopentone anywhere and everywhere. Okay, scoline, atracurium you can use. Okay, these 3 cocktail has to be made. If you don't use this cocktail, the patient will suffer, and you will give a very bad experience to the patient, after which the patient will have a post-traumatic stress disorder throughout his life. So you don't want that stress to happen with the patient. So you need to take care of that. Okay? Thank you.